Hey guys, welcome back to my channel. Today we're going to discuss non-hormonal treatment options for menopausal hormone symptoms. While menopausal symptoms are usually treated with hormonal therapy, there is some science behind the non-hormonal classes. So we're going to discuss that. I'm going to discuss the science and the Menopause Society's 2023 recommendations. Specifically, we're going to cover which non-hormonal medication classes of drugs actually work, how to choose between SSRIs, gabapentin, oxybutynin, and other drugs. We're going to talk about what's different for women with breast cancer. In a future video, I'm going to discuss non-medical, non-hormonal treatment options for menopausal symptoms. There's lots of cognitive behavioral therapy options that have been studied, and I guarantee you're going to find it interesting, so stick with me for the next video. Before we begin, give me a thumbs up, share this video with whomever you feel will find it helpful. I love breaking down the science and bringing you this medical content. So when would a doctor consider prescribing non-hormonal treatment when we've got such great hormonal options? Well, simply put, not every woman can take hormones for their menopausal symptoms. We've got contraindications, which are exclusions, prohibitions for women to take hormonal therapy because it would increase their risk for developing other diseases, or they have breast cancer, which is a common contraindication. And then we also have women who choose not to take estrogen for personal reasons. There's a third group. There are women who did receive hormonal therapy, but after the treatment stopped, their hot flashes returned. It's not as simple for physicians to just go ahead and restart their hormonal therapy because there are some risks at older ages. So usually physicians are going to sit down and try to have a conversation with the patient regarding their personal risk for hazards. The most commonly studied menopausal hormone classes include SSRIs, SNRIs, gabapentin, pregabalin, oxybutynin, clonidine, and a newer class called neurokinin 3 receptor antagonists. We're going to focus our discussion on these classes. Although there are trials studying the effects of lesser drugs, these are few. Now, a note on the placebo effect. When studying these drugs, they compare the effect to placebo, in which the test subject receives a pill that has no drug in it. And the primary purpose is to compare the response of the symptoms in those groups compared to the groups that received the drug. What they found is that the women who received placebo also reported an improvement in their menopausal symptoms by as much as 20 to 50%. This is why it's very important to have a treatment panel with the drug be compared to a treatment panel that did not receive the drug, what we call placebo. The best studied alternative to estrogens are certain antidepressants, such as the SSRIs and the SNRIs. The key points for this class is that they do work within days, not weeks, and they are often effective in both menopausal of natural and surgical origins. They're also important in breast cancer patients, but not every SSRI is safe for a breast cancer patient. Their effects are modest but meaningful, as reported by patients who have suffered from these symptoms. Here is the class of the SSRIs and the SNRIs. For paroxetine, the low dose of 7.5 milligrams is FDA approved. It's not the only drug that's FDA approved for hot flashes. It should not be used with tamoxifen. It may also be expensive and not covered by some insurance plans. I try to find this drug on the $4 Walmart list, but the lowest drug I could find was the 30 milligram dose of the paroxetine. Citalopram is also an effective drug. It starts off at 20 milligrams. It has minimal side effects, and it's actually safe with tamoxifen use. Venlafaxine, an SNRI, starts off at 37.5 milligrams and can be increased to 75. There are some withdrawal symptoms noted with that, and the efficacy is comparable to low-dose estradiol. Desvenlafaxine is a metabolite of venlafaxine. It's not commonly used, but for those women who do take the desvenlafaxine, the standard dose works for the majority of women, but there can be dose adjustments. Not all SSRIs are recommended for the treatment of menopausal hormone symptoms. Sertraline and fluoxetine are not on this list. Fluoxetine and paroxetine can actually significantly inhibit tamoxifen activation, and sertraline has less inhibition, so we prefer alternatives such as citalopram or venlafaxine. For those that are also coming off of the SSRIs and the SNRIs, the tapering has to be gradual because of the withdrawal effect. I use gabapentin commonly for patients that suffer from neuropathy. We're talking about burning, painful symptoms in the legs. And this is a symptom that is most commonly reported by diabetics. But neuropathy can occur in multiple other conditions as well, such as postherpetic neuralgia or even trauma-related conditions. Gabapentin is actually very helpful for nighttime hot flashes because often hot flashes are reported in the first half of the night. And gabapentin is sedating and can actually regulate or stabilize the thermoregulation center in the brain. The starting dose is at 100 milligrams, but this can be titrated up to 900 milligrams. People report improved sleep, and there are fewer daytime side effects if dosed at night. Higher dose gabapentin can actually rival estrogen in terms of efficacy, but the side effects of the high dose limit its use. Pregabalin is another option in this class, but it's less studied, it's more expensive, and gabapentin is usually preferred. Oxybutynin was originally designed for an overactive bladder, and this can lead to urinary incontinence. Oxybutynin has been found to help with that, but it's also been shown to help with hot flashes. One of the most common side effects, though, is dry mouth, constipation. Doses need to be at 5 or 10 milligrams. And there needs to be caution because the studies did show some cognitive decline with oxybutynin. So you don't want to use this in someone who has a family history with dementia or is already struggling with their cognitive abilities. Clonidine is a drug that's often used for blood pressure control. I'm familiar with that and use that drug when I'm struggling to treat blood pressure with 3 or 4 more common pharmacologic classes, but it has been shown to be somewhat modest in terms of hot flashes. Side effects include sedation, dizziness, and dry mouth. It is rarely used, but when used, it's the transdermal approach that has been found to be more effective. Neurokinin 3 receptor antagonist is a newer class of drugs. I actually had to read up on this one because it's so new. Fezolinetant is one example, and it is FDA approved. What happens in menopause is that the estrogen levels fall, and this pathway of neurokinin B signaling actually increases, which leads to a unregulated and unstable thermoregulation center. The fezolinetant blocks this pathway. Clinical trials showed upwards of 59 to 64% improvement in hot flashes. It improves sleep quality, and it's also well tolerated. Now, the FDA does mandate that the liver enzymes be tested because it metabolizes in the liver and can cause some liver injury in some individuals. So this is simple. You give a blood test on the initiation of the drug, and then every month times 3 months, again at 6 months, and then again at the 9th month. They're looking at liver enzymes and bilirubin levels. It hasn't been studied yet in breast cancer patients, but it is promising. Here are some key principles for women that have breast cancer. Non-hormonal therapies can be effective. You want to avoid paroxetine and fluoxetine with tamoxifen. Citalopram and venlafaxine are better options. SSRIs do not interfere with aromatase inhibitors. Gabapentin can be helpful if the symptoms of hot flashes are primarily at night. And fezolinetant is promising but not yet studied in the breast cancer population. So here are our conclusions. Non-hormonal therapy treatments do work for hot flashes if you have the right one and your symptoms and tolerance levels are factored in. The symptom pattern is important. When in the day are the hot flashes? Is there a history of breast cancer? What about sleep and mood disturbances? Is there some coexisting depression or anxiety? All these are important, and the physician will discuss these in an individualized fashion in a shared decision-making process. Stay tuned to my next video because it's going to get interesting. We're talking about treatments that aren't medications and are not hormones. Do they work? Find out with me. Until next time.